In this next section, we're going to talk a little bit about the different types of fluids that we use to replace patients that are hypovolemic. And that includes crystalloids and colloids. These are the two major types of solutions. Crystalloids are small molecules and electrolytes that are dissolved into a solution. This includes small molecules such as dextrose, or electrolytes like sodium and chloride, and electrolytes that can be found in lactated ringer and plasmolite and normosol. Those solutions are known as balanced solutions, and they have various molecules including potassium and chloride and several other agents. Colloids, on the other hand, are larger molecules. They are dissolved and suspended in solution as well, and that can include large molecules that are proteins like albumin, or complex carbohydrates like hepatostarch or dextran. Overall, albumin is the primary colloid and the one that we're going to talk the most about today. Blood is also considered a colloid as well, and we will do transfusions of blood in patients that have blood loss, and that's what's their cause of hypovolemia. Overall, we're going to focus on albumin versus these other agents today. Now, crystalloids and colloids have exclusive advantages and disadvantages. So let's start out with crystalloids and what their advantages are. One, crystalloids are less expensive compared to colloids. Colloids are usually made of either of natural proteins or maybe semi-synthetic proteins versus crystalloids, which are usually made of just dissolving sodium or potassium or whatever into solution. That also makes them non-allergenic compared to colloids, which you can mount an allergic reaction to, including a risk of anaphylaxis. So just remember, these are pretty expensive. However, they do come with some disadvantages too. Colloids spend a lot more of their time in the intravascular space. I remember how I told you that total body water and how much of our volume is made intravascularly will come back to haunt us. This is where we talk about it. Colloids overall stay in the intravascular space and maintain almost all their fluid there. For that reason, instead, you're going to need much larger volumes in order to get the same amount of volume of crystalloid where you would get colloids. Also, since they don't stay just right in that intravascular space, they can go throughout the entire body. It does increase your risk for overload. That being said, crystalloids are used much more frequently than colloids, and the reason being is because even though we've tried again in several different studies, there's never been an advantage seen whenever we use colloids versus crystalloids. So they have a higher safety risk with the anaphylactic reactions, and they have no advantage in shock, plus they're more expensive. For that reason, crystalloids are used much more frequently. So let's talk about some of the different crystalloids. And again, I told you before, sodium chloride, balanced salts such as lactated ringer, and dextrose are the most common used. You'll see here whenever we talk about what they're used for, that dextrose is actually not good for fluid resuscitation versus sodium chloride and lactated ringer. Both are used for fluid resuscitation, including sepsis and volume depletion. Lactated ringer is used much more frequently in post-surgical patients, and the reason for this is just because it's been a long time in practice that surgical or surgeons do prefer lactated ringer. Sodium chloride is used for patients that have hyponatremia to help replenish their salt stores. Now, you'll notice here that dextrose in water is used in hypernatremia or in combination of maintenance fluids. The reason is that they're used for combination maintenance fluids primarily because since they are made of sugar, they can be used as somewhat of a bridge between patients not getting food to total parenteral nutrition or TPN. So it kind of gives them just a little bit of nutrition while we're waiting. Dextrose in water is used for hyponatremia because it's known as free water. Because once we give it in our body, the dextrose gets completely metabolized into CO2 and H2O, and it's already in water. So for that reason, it pretty much just gives us water in the solution. Now, we cannot give sterile water IV. The reason being is because it's so hypotonic that it would just kill you. So this is kind of your replacement here. And you guys will talk about this more whenever you guys talk in the hypernatremia section. Now, each of these do come with their specific side effects. And I want you guys to know these so you know that if a patient does present with any of these things, that this is the one I'm supposed to use, this is the one I'm not supposed to use. So let's start with sodium chloride. One problem is that sodium chloride does have a risk for hyperchloremic metabolic acidosis. Also, it has a risk for hypernatremia. So if a patient is already hypernatremic, we do not want to give sodium chloride. If a patient has an acidosis, or a hyperchloremic acidosis specifically, we do not want to give sodium chloride. There have been some studies that have shown that sodium chloride is associated with an increased risk for acute kidney injury. Acute kidney injury is not a contraindication for sodium chloride, especially if they have a compelling indication. However, you are going to see probably when you guys get into practice that more and more doctors are moving towards using lactated ringer instead. Also, normal saline is slightly hypertonic. So if you do know that a patient is in a hypertonic state already, it's best not to use it. Lactated ringer also can have its issues. Number one, lactated ringer and other balanced salts do have potassium in them, unlike normal saline. So if a patient is hyperkalemic, you want to avoid lactated ringer. If a patient is hyponatremic, you also want to avoid lactated ringer because it has slightly less sodium than our normal body. So if a patient's hyponatremic, you want to reach for the sodium chloride. You do not want to, and you want to avoid lactated ringer. Versus if a patient is hypernatremic, you may want to use lactated ringer or D5 water and not sodium chloride. It shouldn't be used in liver dysfunction because those patients can have a risk for building up the lactate. It does have a risk of microthrombi if you give it with another calcium or a calcium-containing solution. So a good example of this is an antibiotic called ceftriaxone. Actually, it's formulated with calcium. And so when you give those together, it can cause a risk for microthrombi. So if somebody's receiving something that has calcium in it, then you would want to avoid it. For our purposes and for exam purposes, you would be specifically told that that solution has calcium in it. But in real life, you may have to look it up. And it is actually slightly hypotonic. So if a patient is hypotonic at the time of needing fluids, you may want to avoid lactated ringer or other balanced salts. D5 water, you do want to avoid if a patient has high glucoses, if they have low sodium, because as I mentioned before, it's actually used in hypernatremia to decrease. And it only modestly increases your overall volume because of how it works. So for that reason, if a patient is severely hypovolemic, you do want to avoid D5 water. And again, it's because it's free water. I do not want you guys to memorize this. This is just FYI. But if you're curious about how these solutions line up with each other, you'll see here that this up here at the top is the normal body's volume. As I mentioned before, normal saline is slightly hypertonic compared to human plasma versus lactated ringer is slightly hypotonic. You'll see how sodium chloride actually, the reason that it causes so much metabolic acidosis is because it is a little bit acidic, versus lactated ringer is actually much closer to the body's normal pH. You'll see how this has extra sodium versus lactated ringer, which has less sodium than the normal body's volume. And you can go on and on and on and on. This is the amount of potassium these balanced salts have in their solutions versus normal saline that has none. And then the calcium that's contained in them. Again, this is just for your information, but it's kind of me showing my work. Now, in comparison, let's talk about colloids. Albumin comes in two different solutions, 5% and 25%. So 25% is technically hypertonistic, and it actually will bring almost all the fluids intravascularly. So it's used primarily in patients that receive an excessive loss, usually due to paracentesis. Not that you need to know that, but just so you know, like this is not typically used as a volume depleter, versus the 5% is used commonly. Now, some of you guys might be like, but Dr. Joyner, you told me this is expensive. So if the 5% and the 25% are about the same price, why can't I just add water to it? Well, the risk for infection and anaphylaxis that is associated with this 5% with albumin has really mostly been documented in people who have either added water to the 25% or tried to reconcentrate it. So once it's in its bottle, until you put it into the patient's body, you're not really supposed to mess with it. And we use colloids when patients have crystalloid resistant hypotensive. Overall, they're generally safe, but as I mentioned before, you do have that risk of anaphylaxis and infection. Now, this is something important to know. So, as I mentioned before, we have these different types of solution that are used differently. And I wanted to give you guys an idea of why that is. So, just to give you an idea, this is your intravascular fluid that IV fluid that you're giving a patient, right? And if our body was this box, this is the intercellular fluid. And remember, this is about 2/3 of your body's fluid, versus this all would be your extracellular fluid, which is about 1/3. This is your interstitial space, which is about 4/5 of this 1/3. And this is about 1/5. This is your intravascular volume. Now, whenever I give IV fluids, depending on the type of fluid I give a patient, it's going to determine where it goes in your body. So if I give water or dextrose, as I mentioned, this is free water. Promise me you'll never give anybody sterile water, but just so you know, dextrose is free water. So that means that this dextrose is going to become CO2 and H2O, and it can freely go amongst all these different membranes, meaning that it goes equally into the intercellular fluid and the extracellular fluid. Normal saline, on the other hand, or lactated ringer, those other crystalloids that we've talked about, they actually do not cross, or they maintain the tonicity to make them where they do not cross into the intracellular fluid, and they just stay in this intravascular fluid. Now, if I gave equal amounts of dextrose and normal saline, it's easy to see how more of it would remain in the intravascular fluid. Remember, intravascular fluid depletion is what causes that hypotension and all that tachycardia that is associated with being hypovolemic. And whenever somebody is in sepsis or in shock, we want to make sure that we get plenty of intravascular volume. So for that reason, we want to make sure that what we're giving patients does remain in this volume. Now, if we give a patient blood or colloids, 100% of it just stays in the intravascular volume because it maintains tonicity to keep it into the intravascular fluid. So, if I were to give a 1-liter infusion of each of these agents, so normal saline, lactated ringer, Normasol, you'll see that all of them usually give you right at about 1/4 of it remaining in the intravascular volume. D5 water, because it goes in both the intracellular space and the extracellular space, is only going to give you about 100. Albumin, 100% of what albumin 5% I give ends up staying into the intravascular space. Versus the 25% albumin, which I talked about before, actually will draw water from the extravascular space into the intravascular space. So if I give 100 of it, it goes into the 500. And then hetastarch is just like albumin, where it does the equal amount of expansion. However, remember that whenever you use hetastarch, you increase your risk for coagulopathies. What I want you guys to get from this is just to show you that whenever I give fluid, it can go into the inter and extravascular space. This is the reason why crystalloids have that increased risk of pulmonary edema and volume overloaded versus albumin, which has that lower risk. However, remember, intravascular volume repletion does not mean that it is a better solution for a patient. It's not been shown to be any more effective in clinical trials.